It's usually recommended that if you can continue to trust the patient, maybe you can make an exception and go on, but you're going to have, there's got to be consequences, and there's got to be a plan for how you're going to deal with the future. To reduce risk, there's the opioid risk tool. Dr. Belgrade at our pain clinic uses something called the DARE. It's just a questionnaire that gives you, that you can answer, that gives you a score, and then the score can determine the risk that this is going to be a difficult patient to manage on opioids or not. This opioid risk tool, of all the ones, was found by research to be probably the best one. Recognizing manipulative behaviors when I'm treating an addict with chronic pain. The assumption I had 20 years ago was that if a patient had addiction and mood-altering chemicals were given, that would exacerbate and aggravate and stir up their disease of addiction and create drug-seeking and denial and craving and more pain. And I saw that a lot. So then you take a patient that has just had pain and maybe addiction that was in low manifestation, and just make it flare, and now you've turned a addict patient and a pain patient into a manipulative patient. This is true, but not always. Sometimes the pain is real, and the patient persists, and the patient suffers and seeks another doctor. It may be best to prescribe in a controlled way. Manipulative behaviors, patients with their addiction aggravated and develop the manipulative behaviors can look like this. Present very dramatic and compelling but vague symptoms. Subjective complaints with no objective signs. Make a self-diagnosis and specifically request a certain drug. Show no interest in a diagnosis, further tests, or consults. A classic one is coccyx pain. You know, there's no way to tell somebody you don't have pain in your coccyx, but when you do all the tests, they're always negative. There's nothing to see. That's a good one for addicts to come up with. Rejecting alternative treatments and saying they don't work. If you would offer ibuprofen, you offer this, that, and the other thing, Neurontin, oh no, it doesn't work. I've been there, done that. A lot of medication was lost or stolen. You know, I have one patient, when you talk about medication being lost, and the classic, my dog ate it. I have one patient that was on Suboxone, and I've been seeing him for years, and he's doing great, and his drug screens are negative. But darned if he didn't call me one day, and his dog ate a Suboxone. He actually did eat it, and they took it to the vet, and they were worried and everything. But it literally happened. The dog ate it. So, you never know what to believe. They pressure the physician. You've got to do something. You can't let me suffer. It can be hard to deal with a patient like that. So if you're seeing somebody like that has positive drug screens, you're suspicious that a patient is addicted, being manipulative, because they continue to request pain meds longer than usual, or they want more than usual. There's several possibilities. Maybe the doctor is missing a physical problem. Maybe there's something going on that the patient truly does have pain and you're missing it. Needs to be diagnosed and treated. Maybe the patient is having withdrawal symptoms because they're using it wrong. Maybe they're taking it all in the morning and going into withdrawal in the evening. Maybe you need to switch to a longer acting medication. Differential diagnosis, maybe a patient is exhibiting a psychiatric disorder, anxiety, depression, maybe borderline personality or sociopathic disorder. All can lead to the aberrant behavior. And then there's the concept of pseudo-addiction. Pseudo-addiction is drug-seeking behavior due to poorly controlled pain. And the theory is that the patient truly has pain, and they're just begging you and looking like a manipulative patient, but it's true pain. That's more rare than originally thought. Most of the addiction doctors, most of the pain doctors thought this doesn't happen very often. So you got to keep it in mind, but it's pretty rare. The theory is that the aberrant behavior will go away if you treat the pain more. So up the dose of medicine and the pain goes away. But that's similar to the theory that drinking alcohol will go away if you stop the codependency issue. If the spouse behaves nicely, maybe the drinking will stop. It doesn't usually happen. It's like a true addiction. Recreational use, this would be in the differential diagnosis of aberrant behavior, experimentation, pleasure, escape, peer pressure. You can see this a lot in the younger people that say they have pain, but really they're just addicts. Criminal intent, selling it, diverting it, or maybe the patient has addiction. Not for so much the people in this room, but for other doctors that don't know a lot about diagnosing addiction, I always go over what are the clues that a person might be addicted. Unwillingness to consider a taper, person with true kind of chronic pain, or a person pain and addiction but is willing to work with you, usually is willing to think about this. No relief at all from any other methods. That shouldn't happen unless the person might be having an addiction. Patient is getting sedated, somnolent, or euphoric. That shouldn't happen. Strong preference for short-acting rather than long-acting opioids. If a person wants oxycodone plain and not OxyContin, if a person wants morphine and not MS-Contin, that would be a clue to addiction. Running out of meds early, losing the medications, taking somebody else's medications, raising dose on own. This one drives me crazy with people coming in and you prescribe a certain amount and then they're there 5 days early and they say, well, you prescribed it 3 times a day, but I started taking it 4 times a day. I said, you shouldn't have done that. You should have called me. You should have come in. It's a clue to addiction. Expresses concern that the patient pain may lead to use of street drugs. If you don't give me the pain medication, doc, I'm going to go buy it. Buying meds from a dealer off the street, that's addiction. Getting meds from more than one doctor, that's addiction. Forgery, that's addiction. So then, if you have addiction and it's just a mess and the aberrant behavior is out of control, you're not going to treat these people with chronic pain medication. You're going to look at alternative treatments of pain. And this is what I focused on when I talked many years ago, and it's still true. So what are some of the alternative treatments of pain? Physical therapy, they can do wonders with counter-stimulation. TENS is a type of counter-stimulation, a TENS unit. Thermal treatments like ice and heat. Musculoskeletal, like stretch, conditioning, massage. Chiropractic therapy would be under musculoskeletal treatments. Orthotics, whirlpool. Occupational therapy can also do wonders for treating chronic pain. In that category would be vocational retraining, creative enhancement, anesthesia departments. A lot of the Pain Institute, MAPS, that's what they focus on, probably because that's where the money is, that they do procedures. They can get paid for it a little better, but anesthesia can relieve pain with blocks, sympathetic blocks, trigger zone injections, steroid injections, analgesic blocks. And then there's medications other than the opioids for treatment of chronic pain. Non-steroidals, ibuprofen works very well. Scheduled sustained high doses, you can alternate them with Tylenol. Tricyclic antidepressants can be used. Anticonvulsants, in that category would be Neurontin. Tegretol, Dilantin, Lyrica are all in that category. Clonidine has been used for chronic pain, in that it probably helps with the pain, but it also relieves any opioid withdrawal that might be going on. Topical lidocaine, the lidocaine patches, Pain Clinic frequently recommends that. I have to say I've not been too impressed with how these work, but if somebody gets relief from it, so be it. I'm not going to argue with it. It's pretty harmless. Neuropsychological approaches such as biofeedback, relaxation, hypnosis, behavioral therapy, psychotherapy. And then acupuncture is another alternative for the treatment of pain. And then there's the whole field of alternative approaches. My wife used to be involved in this, in energy therapy, guided imagery, healing touch. Tremendous relief if the patient is willing to pursue this, they have an open mind, they do the work, and it does require a lot of work. So then you're back to the office, back to prescribing opiates. You've tried the alternative treatments, maybe they're not enough. You're going to go ahead and prescribe opioids to somebody with pain, with addiction. You have to have a pain note, and that note should be the 4 A's. How much analgesia are you getting from your treatment? How have the activities of daily living either improved or not getting any better? What are the adverse effects of the chronic pain medicine? Constipation is one, sedation is one. And what is the evidence or the lack of evidence that there's aberrant drug-seeking behavior? In the pain note should be the results of the urine drug screen. There should be a note of a brief physical exam. Never prescribe opiates without seeing the patient periodically. It sounds so simplistic, but sometimes people keep getting their meds refilled and refilled, and nobody's seeing them. The doctor has just kind of done it the easy way and just refilled the medications. Never go more than 3 months without seeing a patient. My Suboxone patients I see every month. I have one guy that I've been seeing for years, and he's doing so fine. He's always done fine that I said, you can come every 2 months now. So he did that for a little bit. And then he came back to me and said, can we go back to every month? It just felt safer to come in and have a check-in every single month. So I see all my Suboxone patients every month. Buprenorphine for pain is safe. There's a ceiling effect for euphoria. But less of a ceiling effect for respiratory depression and sedation. I mean, just the opposite. There's a ceiling effect for sedation, respiratory depression, euphoria, but less of a ceiling effect for pain relief. And it seems to be more effective for neuropathic pain, nerve pain. 1 milligram of buprenorphine is equivalent to 30 milligrams of morphine. It's a strong medicine. Anybody that comes into treatment comes to me and says my doctor was giving me 24 or 32 milligrams of buprenorphine or Suboxone. That's malpractice. That's way overprescribed, and that's out there. There are some bad Suboxone doctors out there, unfortunately. Some bad Suboxone clinics. And fortunately, we always wonder, why do they limit? Why can't they open up more Suboxone and get more doctors do it and let the doctors have more numbers to prescribe it to? That's why. I mean, there'd be Suboxone mills, doctors prescribing it without seeing the patients, just charging. So there are some nasty parts to it. I mentioned my part about the receptor of being filled by these Suboxone. One study on buprenorphine for pain in patients with addiction quoted 80 to 100% pain relief. So it was a small study, but good results. So what's the standard of care? The standard of care for treating pain with patients with addiction is to start them on a long-acting base drug, something that lasts 12 hours, doesn't go up and doesn't go down, like OxyContin, MS-Contin. Use a short-acting drug for breakthrough pain, usually 15%, up to 15% of the total daily dose, but mostly it's the base that we look for. If they're taking short-acting ones 4 times a day, well, that's basically a long-acting one. You might as well switch them over. That's the standard of care. The conclusion, long-term opioid therapy may be appropriate, but always ask, what is the conventional practice for this type of patient with this type of pain? Are there equal alternatives? Because this is a risky endeavor. What is the risk of adverse effects? What is the risk of abuse, addiction, or diversion? Patients with chronic pain are difficult to treat. Patients with addiction are difficult to treat. They relapse a lot. They're a challenge. Patients with both, really difficult to treat. It's the ultimate challenge, but possibly can give you the greatest reward if you can get somewhere with this. And that's all I've got. I can open it up to questions, if there are any.
I guess I have one question. I'm pulling the microphone. I'm a music therapist, and I was interested that you didn't mention music at all, and we have quite a bit of evidence of that, so I don't know if you included that when you talked about relaxation, guided imagery, creative outlets with OT, or it's just not something that you looked into.
Point well taken. I'm glad you said that. Yes, Jeff.
I have heard just recently that a program used Neurontin. I had just heard recently that a program was using Neurontin as a standard medication for every patient. I think for pain control or for anxiety or whatever. Have you ever heard of anything like that?
Well, I've certainly heard of Neurontin as being used for chronic pain, and it's been around a long time. I'm impressed. I think that's one of my first-line treatments for somebody with pain. It was initially developed and is accepted for treatment of diabetic peripheral neuropathy. That's really good for nerve pain. It is used for anxiety too. It's a very good medication. So any patient with chronic pain, yeah, should be considered for Neurontin. Also called gabapentin. That's the brand name of it. Yes.
So my patient that you also have seen, that talked about that because he's been on Suboxone since it came out, that he now needs about double the dose of what would be standard. Is that BS?
It might be BS. I've not had any patients, Suboxone patients of mine, that we've ever needed to increase the dose.
Okay.
I've always decreased the dose over time.
Well, and that's kind of what I've seen with ongoing care is that it's
Yeah.
always going the other way. And he's
Right.
telling me I need to be on minimum 24 milligrams of Suboxone. And
I would have trouble believing that.
Okay.
My red flags would go way up.
mine did too.
Yes, Cindy.
Heroin addiction. And
Young man with heroin addiction.
yes, and he said that because of the way the Oxycontin changes are and how they're being manufactured now, as you described, that they can't be snorted, that's the reason why we're seeing an increase in heroin addiction. Do you,
Yeah, that makes sense.
is that?
The addict they need that POW, that immediate release. They're not being able to get the old OxyContin. They don't like the new one. Heroin is available. It's on the streets. It's
Cheaper?
cheap.
Yeah.
And a lot of people that were on OxyContin are going to heroin, especially the young crowd, especially the addicts, the ones that aren't taking it for pain. They took the OxyContin at a party.
Yeah.
They liked it, and then they took a little more, and then they went on to use it daily, and now they're going to heroin. So we see a lot of that.
I have one other question. What do you consider long-term pain treatment for chronic pain? What's long-term considered?
Lifetime would be long-term. Chronic pain is over 6 months, any pain that's there for over 6 months. Chronic disease is over 6 months. But if you get to the point where you're diagnosing chronic pain, you're basically saying that this person has a disease or a condition that we really don't have an answer for the pain, to get rid of the pain. So we're going to treat the pain. Now, there's multiple ways to do that, like, as we said, alternative ways. But one of the ways is with opiates. So you're basically saying this is a chronic condition like diabetes, like arthritis. We're going to treat the pain, and there's really, you go in there thinking that this may be lifetime. Now, if something happens, a person has arthritis and has remission, has a cancer that goes away, loses 100 pounds and something else is relieved, there's a big change in the person, and the pain goes away, so be it. But when you enter the treatment, you have to be willing to say that this may be lifetime treatment. Yeah, Ollie.
What's your take on using methadone as a method for long-term pain relief?
Methadone has its own problems. There are medical problems with methadone. There's EK heart changes with methadone. There's a lot of sedation with methadone. And most of the pain doctors are finding they used to be more in favor of it. Even you would think it would be good because it's very long acting. It can last for 24 hours. But for treating pain, it doesn't seem to be as good as some of the other ones, the ones that last for 12 hours. So I would never use methadone. I'm not comfortable with it. I'm not familiar with it. So I would never use it. Legally, a doctor can prescribe it for the treatment of pain. Without a license, without any type of a monitoring system, legally he can. You cannot prescribe it for keeping somebody off of opiates, but you can prescribe it for pain.
I have a question about long-term chronic back pain in particular. I had heard a physician from UCLA talk about implantable drug pumps. I think he might have used it off-label. It was probably used for cerebral palsy. And there's a catheter that delivers drug to the intrathecal space of the spine. And he was having tremendously good outcomes with his clients, and they weren't overly sedated, getting good pain management, and having improved quality of life. What do you see with that?
That's an acceptable treatment. The pain clinics, the big ones, they have people that will do that intervention. It's pretty invasive to have a catheter in your spine. So you would want to limit it. And it would be specific to certain types of pain that are generated usually in the spine, lumbar disc disease, chronic lumbar disc disease. The medicine that they put into the spine can be baclofen as a muscle relaxant. It can be clonidine. It can be morphine. It can be a variety of different things. But it's an acceptable treatment. Pretty invasive, though. Question is about the abuse of Suboxone. It's there, and it's becoming more and more the longer Suboxone's out. There's a lot of Suboxone seeking. Now, addicts on the street, the heroin addicts, the OxyContin addicts, they know that if they have a supply of this, or if they can cop some from a friend, so some of these people that are getting 24 and 32 milligrams and they don't even need it, so there's a market for it. If they have some and they can't get their heroin on a weekend, they can take a Suboxone. And initially, they were really screwing it up. They would take it too early and just put themselves into withdrawal and get sicker. But they're getting a little better at it. You'll see addicts now that have learned through word of mouth how to use the Suboxone. So it has become a street drug. It's got street value. It's not a drug that they take just for the sake of, ooh, I like the Suboxone, because it only stimulates, and you only get so high with it. If you took it, or if anybody that's opioid naive took it, you'd feel it because your opioids in your system are zero. If somebody has a tolerance to heroin or whatever, Suboxone doesn't really get them high. It just takes them up to kind of normal. But it's out there, unfortunately, so the doctors that prescribe it need to be careful, watch for, just like now, it's become like we treat pain. You got to do drug screens, you got to see people frequently, you got to count their medication. There are some risks with Suboxone now. Yes?
I think the term is intrathecal pump.
Mm-hmm.
Is that the same?
Same thing, right?
Same thing as with the catheter?
Intrathecal means into the spinal canal, yeah.
Okay, and so am I asking about the exact same thing that you were? Okay.
Yes.
All right. So that's
The medicine is in the pump and it's infused into the spine.
And the
Through a
pump
pump.
cannot be removed by the patient? I mean, it's not something that they can adjust the dose on? I mean, it's preset,
I don't know.
because it's internal? You don't know, okay.
No, it can be implanted. It can probably also be one that they could wear in their belt. Any other questions? Uh-oh.
How do you feel about drug companies advertising things like sleeping pills and things to keep you awake for shift disorder, that sort of thing? That's a political thought on my part.
I've never been fond of pharmaceutical companies. In the years that I've been in practice, our philosophy has never been to allow a pharmaceutical representative into our office, so we have no contact with them. We don't get our education from them, so I don't know if it's any different for the drugs of abuse than it is for Lipitor or whatever, so. Yeah. I think I'll let you go, everybody.
For those folks that are here from Adult CD Outpatient, that are going to come meet with me a little bit